Good afternoon, everyone. My name's Teresa Woodruff, and I serve as your director of the Women's Health Research Institute. And on behalf of our institute and leadership committee, I'm very delighted to welcome all of you to this special February forum where we'll be celebrating the recent NIH policy to include females, I don't know why I'm crying, in basic bench research. This is really a celebration about everyone in this room who has been such strong advocates for this, what we thought at one point was really a moonshot, and here we all are standing on the surface of the moon. In October of 2015, the NIH released the final policy language associated with the inclusion of sex as a variable in scientific research, together with additional guidance on improving reproducibility of research findings. This is the notice OD 15102, and I think this number is going to go down in history as one of the most important changes that will occur in biomedical science, at least for the next decade, and is going to lead to many new discoveries that we are just expecting over time. These new policies became effective in all grants on January 25th, 2016, and directions have been provided to the Center for Scientific Review regarding the review elements. Northwestern University's Women's Health Research Institute has been strong advocates for sex inclusion and reporting, and we're delighted that now sex is a part of scientific research in the same way that temperature, dose, and age are currently regarded. From the beginning, our Institute's mission has been to facilitate and advocate for the inclusion of sex as a variable in all institutional research by bringing the best minds together to advance the field of sex-based biology. This is truly a victory for all of us. I'm delighted to welcome Dr. J Walsh, Vice President of Research at Northwestern University, who will provide a welcome to all of you in a moment. Joining Dr. Walsh as representatives of the university are Eric Nielsen, our Vice President for Medical Affairs, and the Louis Landsberg Dean at the Feinberg School of Medicine, Dean Harrison, President and Chief Executive Officer of Northwestern Memorial Healthcare, Phil Hochberger, the Executive Director of Research Facilities. I'm also delighted to welcome Congresswoman Jan Schakowsky, who is here to share this joint accomplishment, and we'll ask her to make a few remarks in a moment. Later, we'll also welcome my friend and colleague, Dr. Sarah Kinsinger, who is going to give an abbreviated overview of her talk on behavioral treatments for women with irritable bowel syndrome. She'll present the complete lecture later this fall. So let me take just a few moments and try and gather myself. I'm actually shaking and trying not to cry still. I don't know if you can tell that. This is our 8th year of these forums, and for many of us in the room, we've been here together every month for the last 8 years. So I think it's just so wonderful that we can all stand on the precipice of this really remarkable new notice. So I'm going to just take a few moments and remind us of what we've done to actually get here to today's celebration. So to start with, we've had a hypothesis. As you know, we think about things in a hypothesis-based way, and we think that really the next generation of biomedical advances that improve the lives of all people will require fundamental discovery research that includes sex as a variable, the same as we do for time, temperature, and dose. And joining all of us in this initiative has been an extraordinary leadership council, many of whom are here in the room on this side. And I really want to extend and acknowledge all the members of the Women's Health Leadership Council for your help in making sure that this fundamental announcement could come out. The notice NOT OD 15102, consideration of sex as a biological variable in NIH-funded research, was given to the research community that said that now we must have sex as a biological variable. The Women's Health Research Institute, as many of you know, have been signatories to a number of letters, including letters to Francis Collins, urging that this occur over time. And many of us have advocated with our Congress people, including Jan Schakowsky. And Collins said, most scientists want to do the most powerful experiment to get the most durable, powerful answers, which he said in a quote to the New York Times last year. But for most of us, this has not been on the radar screen as an important issue. And so I think the important thing that we all did here in this room is to make it that important, imperative issue that Collins and the NIH now had to listen to and recognize that this was going to be the next step in a powerful new era of biomedical research. And why did we really, what were some of the things that became apparent that were part of the data leading to this new notice? Well, one was the Institute of Medicine's perspective, Shorter Lives, Poorer Health. And it looked at the health of men and women across the United States. And this is one of those staggering reports that really required there to be action. And you can see that for many women, our health is worsening across the United States, as denoted by the red. And so we have poorer health and, in fact, shorter lives than our female constituents in other countries around the globe. This was a real clarion call to action that needed to be addressed. And we also wanted our colleagues at NIH and the leadership to realize that it's not just about XX and XY chromosomes. It's not just about having estrogen or testosterone. It's also about the microbes that populate our colons and our guts, and this leads to sex differences in health and disease, as well as overall physical anatomy. And those of you who have been members of this forum over the last 8 years have heard talks on each of these different topics over this time. We also wanted to make the point that women's health is not just about pregnancy and about pregnancy and having a child. It's also about all the different internal organs within our body system. And so in the Women's Health Research Institute, we've embraced this broad perspective of ensuring that when we say women's health, we mean all of women's health. So how did we get here? And there's a little bit of license with this timeline that includes the Northwestern perspective. But in 1921, Marie Curie visited Northwestern and was given an honorary degree. And she met with male and female scientists, students who were here at the time, and really began to inspire a whole generation of women, not all of whom could go into laboratories at the time, but leading to ultimately women emerging in faculty positions by at least the 1960s. In 1974, Nina Schwartz, professor emeritus at Northwestern and the immediate past director of the Center for Reproductive Science, together with a newly formed AWIS, sued the NIH, forcing them to stop all appointments to study section until women were included. In fact, women were not included at the time, and the NIH, based on this Northwestern leadership, did in fact go ahead and put women onto study section. We then had the action by the FDA in 1977 to bar women of childbearing age from participating in any early stage research. And this was because of true tragedies and breakdowns in our clinical pipeline with thalidomide and DES. And in the absence of having basic science linked to translational and clinical medicine, we had these terrible tragedies that occurred and stopped all women from participating in any research. In 1985, the Public Health Service reported, though, that this exclusion of women from research was actually detrimental to women. And in 1986, NIH adopted guidelines that urged the inclusion of women in NIH-sponsored studies. But the GAO then ultimately reported that these guidelines were not being followed, and that required Congress to become active. And there were laws enacted that now required the inclusion of women in clinical studies in all funded NIH research. And so this is where the policy and Congress really became important in ensuring that now we have women included in translational and clinical studies. And we required, once again, congressional action and congressional pressure, particularly from the Women's Caucus, to once again urge NIH to do the right thing, and now to include female animals as part of basic bench science. And this is the new notice that we're celebrating today. So that gives you a little bit of the background, and of course, bringing you a little bit more up to date. In 2007, we founded the Women's Health Research Institute, and in 2010, a Nature paper was published that I penned, which was a call to action on including sex as a basic variable in biology. And it was when I published that I thought, well, as soon as this gets published, we're now going to have real action. And I, in fact, called Marla Paul, who's been a great participant participant in this work and said, well, we're going to need a media response plan. We're going to have a lot of people calling us. We've now called upon everyone to include sex as a basic variable. And she said, okay, I'm ready. And we waited and we waited and we waited. Nobody ever called. And frankly, until about 3 years later, when there was something, the Ambien crisis occurred, and producers from 60 Minutes called and said, you know, there's this paper that we've seen, and we just can't believe it's true. Is it actually true that women are not, or females are not included in basic studies? Is that really where we are? And I said, well, yes, that is true. And I said, well, I happen to have a media response plan right here, ready to go. It happened to be a little delayed, but that was really the important thing. And so Leslie Stahl came to Northwestern. She interviewed my friend and colleague, Melina Kibbe, and female Northwestern rats were the stars of the entire program, because it really showed that without studying males and females, we really didn't have a pipeline that would allow us to make the breakthroughs that we want to make at the pace that we want to make them. The Leadership Council then sent one of several letters to Francis Collins urging that he enact policy that would require basic scientists to include females as part of their ordinary scientific research, or demonstrate why they shouldn't. And that's an important distinction of this policy that was very important, that you don't have to use you don't have to use males and females. You just have to justify the sex of the animals. And so starting that conversation and that thought process is an important part of what this new notice is going to do. And then once he acquiesced and said that in fact he would in fact move forward with this policy, Stephen Colbert, great alumni of Northwestern University, came out and focused on what had been this policy, and really using satire to put a very fine point on the fact that we had not in the past been using females. But the implementation then took constant pressure. As Jan will tell you, it's really great if someone says, yes, we're going to do this, but you have to stay the course and make sure that the policy actually gets written, and then it gets put out to the NIH constituencies. And we had to continually make the case that in fact including sex as a biological variable was critical to science. And I'm not sure why we had to keep saying this, but we did. And your Leadership Council continually put the pressure on. We went to the Hill to talk with our Congress members. We wrote peer-reviewed papers and editorials to make sure that people continued to understand that this was a major issue. And Melina Kibbe published a beautiful paper saying, well, in fact, not only is this a problem today, the problem is getting worse. And in this study, looking at the sex inclusion issue in surgery journals, she showed that there were fewer females being used in basic science research in the studies that were published in this major journal. And she then asked, well, what about those diseases that are sex prevalent? Maybe we're only studying diseases that impact males. And so she looked at those sex prevalent diseases and found that 44% did not specify the sex studied at all. And of those that did look at the sex that was studied, oops, I bet you can guess what this next one is. It should say 88% were male. And so these were the continual scientific peer-reviewed data that we continued to provide in addition to the editorials that made it impossible, I think, eventually for this new policy not to be implemented. For many people, as we kept actively working on this policy, people thought, well, it was hard to disseminate this to the public efficiently. It was tough to generate the political capital to get this done. There were a lot of other healthcare issues that were being addressed by Congress. It was difficult to boil down to one sentence. It was too expensive. But of course, we left it to Stephen Colbert, and for some reason, that's not coming up, where he actually said, well, I'm going to actually get to his clip in a moment. I had his one sentence there that basically said it's really important to exclude half the population. That's what all good scientists know. But our messaging has now been effective, and as of January 25th, 2016, the intellectual arguments that the biology of sex informs health and therefore matters to all stages of biomedical research is now there. The economic issues, the inclusion of sex in basic research is really a cost-effective way of knowing what the basic mechanisms are that ultimately will reduce those thalidomide and DES casualties that occurred in our past. And it will accelerate the advancement of medicine to targeted population as we move more and more towards precision medicine. And from a personal point of view, there must be something more than having my baby and then waiting for my cancer, which Steve Falk always says, and I think we all agree with that this is something that really matters to our population, and that ultimately led to this policy. As you know, the Women's Health Research Institute has been bringing women into, or participants into clinical studies at Northwestern. We first launched the Women's Health Registry back in 2008. And importantly, at that time, we didn't have a way of bringing women into clinical studies. And at the time, I would ask many of our chairs of departments, and they would simply say, oh, well, women are too busy. We don't really need to bring women in. They've got many things on their minds. And I thought, well, that seems a little odd. And so we put the Women's Health Registry together, and there are nearly 7,000 women in the registry, many of you in the room, and across the entire state of Illinois. We've matched over 15,000 times individuals to clinical studies, and this has really been exceptional. We did launch the Illinois Men's Health Registry last year, and unfortunately, we're only at 8 men who have participated. So I look to everyone in the room to continue to get the word out about the Men's Health Registry. J Walsh, I know you're in the registry. I'm sure you're in the registry. And this has really been a critical way of accelerating the pace and the quality of the research at Northwestern. And to match that, we now have a sex inclusion toolbox that includes a lot of the basic language you need for all grants that now require this language for review. It's in the approach section. It's not at the end of the grant out in extra material. It's in the heart of the grant. And NCATS is now, or NewCATS is now funding the Institute to create a guide for Northwestern as well as nationally on the sex inclusion issue. So we started with this hypothesis that the next generation of biomedical advances that improve the lives of all people really do require fundamental discovery research that includes sex as a variable. We've built this argument over time with a variety of different topics that you've heard in this forum, and really we are now on our way. So let me now, without any further ado, I'd like to introduce Dr. J Walsh, who's the Vice President of Research. As Northwestern University's Vice President for Research since 2007, Dr. Walsh oversees a research infrastructure and annual research budget exceeding $500 million. He also leads the development and implementation of university-wide research-related institutes that break new intellectual boundaries and advance the work of our faculty and students. Notable examples of this are the Chemistry of Life Processes Institute, the International Institute of Nanotechnology, and the Center for Reproductive Science. Under Walsh's leadership, the Office for Research has made major contributions to the development of Northwestern's core research facilities, including a partnership with the Feinberg School of Medicine to support the Women's Health Research Institute. Please join me in welcoming Dr. J Walsh to our podium.
It's nice to hear all that bio today. I'm plastered between two phenomenal women, Teresa, who we just heard, and Congresswoman Schakowsky, who we'll hear in a few minutes. And candidly, it is just a huge honor. So very nice words for all sorts of things. Teresa, let's be candid. We would not be here today if it weren't for your drive and enthusiasm for this. You know, when I first heard of this, I had most of us when we first hear of it probably were like Francis Collins and said, duh, half of humanity? We probably should study half of humanity. As I'm sitting listening to you, I didn't know where you were headed with the presentation. If you have not heard Stephen Colbert's presentation, I have it. You've got it. You got to go home tonight and YouTube this thing. I mean, it is just absolutely hilarious, and it put a very sharp spike on the whole push that you and others have been doing for so many years. Clearly, Leslie Stahl got it going again after you folks have had a number of really wonderful papers throughout the year. The Nature paper you pointed out. There's a number of others as well. And then, for reasons that, I don't know, maybe somebody way brighter than me can figure out why things stall in society. It stalled. And then, Leslie Stahl did a really wonderful piece that you and Melina did a fantastic job on. And is Melina here today? No. So Melina and I go back and forth. I razz Melina about a variety of aspects of that. And there was also the Stephen Colbert thing, where they're handling the rats. And you know exactly where I'm headed with this. And when you're in my job, one of the things you have to do is make sure that everything is done safely. And we do a lot of training on how you handle animals. And I'm not going to go into the details of how they weren't handled quite like they're supposed to be on TV. But I called Melina, who happened to be doing the handling at the time, and I said, you didn't have gloves on, is really what the issue was. And then one of the veterinarians who was next to me when I said that to her said, Jay, that wouldn't have worked unless she did it the way she did it. And I'm like, yeah, I'm such a dumb guy, didn't notice this. My point is that the public component of this took time, but was absolutely vital and was done really, really well. That brought us to this point where most of us are now sitting thinking we should have had this as a notice from NIH many, many years ago. So we're here today to celebrate that you and your colleagues on the council did a fantastic job with this. You engaged really well with NIH and with Congress, who will hear Representative Schakowsky in a minute talk about this. We had tremendous support from the congressional side, so thank you very much for that. And I look forward to watching over the rest of my career the phenomenal results that are going to come out because of this new notice from NIH that would not have come out if there hadn't been such leadership that exists within this room. So once again, thank you.
Thank you, Jay. And now we have a special message to you and the university from Janine Clayton.
I'm so excited to be here to congratulate and celebrate the Women's Health Research Institute's Leadership Council, who have worked hard on policy issues throughout many different means. I would also like to take the opportunity to congratulate Northwestern University's Vice President for Research, J Walsh, for disseminating clear information on sex inclusion to every investigator and for supporting the Women's Health Research Institute's creation of a toolbox that will help all investigators maximize the return on every NIH research dollar. You're here at a forum with multiple disciplines and perspectives, and that is so powerful because today in 2016, we know that science is a team sport. We're all in the same team. You have basic scientists with clinicians and have bidirectional conversations to bridge the gap between preclinical and clinical research. We know that preclinical research informs our clinical studies, so it's so important for sex to be considered at the very beginning. We see the power of partnership. We've already made great strides together. In fact, in 1993, NIH developed and implemented its inclusion policy, mandating that women and minorities be included in NIH-funded clinical research. Before that, men were predominantly the subjects of clinical studies. Despite that, the findings from those clinical studies were applied to everyone, including women. We've learned a lot, and today, over 50% of the participants in NIH-funded clinical research are women. So we know that we can change the research culture, but we need to do more. So the Office of Research on Women's Health has developed an outreach toolkit, a web-based tool that provides materials and resources regarding the recruitment, enrollment, and retention of women of diverse backgrounds and women in clinical trials. Today, we broaden our efforts to preclinical research. Preclinical research is critically important because it informs the design of clinical trials and clinical studies that determine how we treat our patients. As of January 25th, 2016, All NIH grant applications must address sex as a biological variable and will be evaluated on how they account for sex as a biological variable. We're excited to work together with partners like the Women's Health Research Institute at Northwestern as we move forward in the implementation phase of this policy. It's an exciting time. Scientific and technological advances have moved us forward, and we know more. From bioinformatics and biotechnology to personalized and now precision medicine, we have the tools to move us forward and to advance our understanding of both male and female biology. Applying a sex and gender lens is a powerful lever for advancing our understanding of both male and female biology that will ultimately lead to better, evidence-based treatment that is sex and gender appropriate and individualized for each and every patient. No longer will we have a one-size-fits-all, which in fact was a one-size-fits-none treatment paradigm. Everyone will be getting the treatment that will most likely work for them. I am truly thrilled that Northwestern has truly embraced that sex and gender matter in human health and are going beyond talking the talk to walking the walk. The toolkit will help scientists become aware how to account for sex as a biological variable, and that is commendable. I'd like to end with a quote from Helen Keller. Alone we can do so little, together we can do so much. I am looking forward to partnering with all of you around sex as a biological variable as we move forward in our understanding of how both sex and gender influence health and disease for men and women, boys and girls. Thank you.
Congresswoman Schakowsky was elected to represent Illinois' 9th Congressional District in 1998 after serving for 8 years in the Illinois General Assembly. She's in her 9th term, serving in the House Democratic leadership as the Chief Deputy Whip and as a member of the Steering and Policy Committee. She's a member of the Energy and Commerce Committee, where she's the ranking Democrat on the Commerce, Manufacturing, and Trade Subcommittee. For decades, she identified her top priority as winning affordable, quality health care for all Americans. In 2009 and 10, she played a leadership role in writing and passing historic patient protection and the Affordable Care Act that finally established health care as a right and not a privilege in the United States. She's been a long-standing advocate for women's health in particular and was instrumental in the 2005 advocating for sex inclusion. I've been privileged to work with Jan in her office many times over the past 10 years and was delighted to deliver 2 talks to the Women's Caucus on sex inclusion. Jan is a great leader of the Women's Caucus and a great leader for Illinois, and it's because of her dedication to women that we're honored to have her and to welcome her to our podium today. Please join me in welcoming Congresswoman Jan Schakowsky.
Oh, it is such a pleasure to be here. You can see that in 2011, I was proud to acknowledge the successes of the Women's Health Research Institute at Northwestern, which I'm proud to represent. That is Northwestern University, live in Evanston, and to acknowledge the incredible work of Teresa Woodruff. And I am so happy to be here today for a celebration. And I say that in the context of what I see as an unprecedented attack on women's health, particularly our reproductive health, the availability of contraception, the availability of clinics that treat women, women who want to exercise their constitutional right to terminate a pregnancy. I've never quite seen anything like this. And so today, however, we are here to say we can win when we get together, when we fight, when we are persistent. And I say that now as the ranking Democrat on this committee, the select committee to investigate Planned Parenthood and science meaning fetal research on fetal tissue, the use of fetal tissue as to help advance health care. It's amazing, but I want to say again, we will win if we all stick together, and I want to thank you. And what this victory illustrates is when women are in leadership, it really makes a difference. When we are at the table, we can win. And you know that the saying in politics is, if you're not at the table, you're probably on the menu. And that is exactly, I think, the case that we see. In 1990, Senator Barbara Mikulski and a group of women colleagues drove together to the NIH in Bethesda, Maryland to attend a meeting they had requested. Their goal was to assemble key government health officials to address concerns regarding women's exclusion from clinical research, 1990. As a result of this meeting, Senator Mikulski and her colleagues, through the Congressional Women's Caucus, which I was at one point one of the co-chairs, and I am currently, of course, a member, they were able to establish the National Institutes of Health Office of Research on Women's Health. You just heard its director. So it was because women were finally at the table and in the Congress. Think of this, Barbara Mikulski is retiring this year. She is the first woman to be elected to the United States Senate, not because a spouse died, but on her own. She is still serving, but she is the first. It's 2016. We have a lot of work to do. So the other thing I wanted to tell you about was Barbara Streisand came to speak to a group of women in the Congress. She has established the Women's Heart Center at Cedars-Sinai Heart Institute, and with the slogan, "Fight the Lady Killer." This is about heart disease. More women die of heart disease than men since 1984. And yet I think in many circles it's considered a men's disease. And it is true that less than 1/4 of the participants in heart-related studies are women. And Barbara, who just, between us girls, I have to tell you, was kind of nervous. Isn't that amazing? There was a room much smaller than this where she was talking and she had her notes and she was reading from them and she was kind of nervous, but she presented her case and two women physicians who were talking about the different symptoms that women experience when having a heart attack. And one of the advice was, because we don't want to be ignored when we go to the emergency room, go into the emergency room and yell, "I am having chest pains," even if your symptoms are something else, like dizziness or nausea, if you want to get the attention that you deserve. And of course, we need to know what those symptoms are. But this shows the kind of sexism that exists at every level, including when presenting at the emergency room. So we need to do our work here. The Office of Research on Women's Health has helped to strengthen and enhance research related to diseases, disorders, conditions that affect women, and ensure that women are adequately represented. Francis Collins, who is just one of the most wonderful people, would you agree, Jay? I mean, he's just incredible, but saying that he did not realize that this was a big problem, again, points out to how it is our responsibility, women, to bring it to attention, even of well-intentioned scientists and researchers. There was discussion about Ambien, so it did come to light recently that the sleeping aids for women should be half of what it is for men. I mean, how long have women been sleeping through that, without knowing that knowledge, as Stephen Colbert only could put it so well. So these gender differences are so incredible. Differing doses of medicines is just the tip of the iceberg. Sex differences have been found in pain receptors, liver enzymes, even the wiring of the brain. As one researcher from the Texas Heart Institute said, quote, "The truth of the matter is men and women are very different at the cellular level, at the molecular level, at the systemic level." And thankfully, we do have dedicated and thoughtful researchers like those at the Women's Health Research Institute that recognized that this was a problem early on and really led the fight in order to fix this. So now researchers will be required to account for these gender differences at every stage of their medical research. Studies done on animals or biological test subjects must include both male and female specimens and people, and data from this research will be broken down by gender so we can finally truly understand how procedures and drugs impact each gender. This is such a huge moment for women in medical research, but also in understanding how we can make a difference in the lives of half the population in the world. This is a great victory. I'm so proud to be here today and to celebrate with all of you. Thank you so much.
Thank you so much, Jan, for those comments. It is really an exciting day for all of us, and this forum is typically for us to talk and consider sex-inclusive science and sex differences, biology and medicine. And so today is no different. We are going to have about a 7 or 8 minute abbreviated conversation with Dr. Sarah Kinsinger, whose background and training is in health psychology, and she has experience providing cognitive behavioral therapy interventions to a variety of medical populations, including cancer, obesity, acute rehabilitation, and gastroenterology. She earned her PhD in clinical psychology at the University of Miami, and her research has focused on the influence of partner support on adjustment to illness, sexual functioning, following cancer treatment, and coping with chronic illness. Today, she's here to present just a little excerpt on her work involving behavioral treatments for women with irritable bowel syndrome, and we hope that you'll join us again in October for her complete lecture. We're thrilled to welcome her, and Sarah, please come and present to us.
All right, thank you so much for having me today. It's such an honor to participate and be a part of this forum. And I'm really excited to talk a little bit about irritable bowel syndrome. So this is a condition that impacts a significant number of women in our country, and I'd like to bring some awareness around some effective psychological treatments that we have and can offer to help women manage this chronic disabling condition. So just, I'm sure many of you are aware, but just as a kind of a refresher of what irritable bowel syndrome is, so we really could think of this as a chronic pain condition. And a woman can be diagnosed with this if she has chronic abdominal pain that's associated with changes in stool form or frequency and is alleviated by having a bowel movement. I think it's important to note, though, in addition to these, bowel symptoms, women also report a whole host of other symptoms that accompany this. So, for example, 75% of women are reporting significant symptoms of bloating. There could also be nausea, early satiety, urgency. So there's this whole host of symptoms that can be very disabling and impact patients' quality of life. So this has a significant burden on the world's population. So prevalence rates can range from 10 to 20% depending on what diagnostic criteria we're looking at. And these patients can comprise a significant portion of a gastroenterologist outpatient clinical practice, as well as primary care physicians practice. And the condition also has a significant burden on healthcare resources, so to the tune of over $20 billion annually. And this is related to direct expenditures related to frequent office visits. Patients are often shuffled around to different specialists. Unfortunately, patients can have unnecessary surgeries, so there's a higher rate of hysterectomies among women. And then also the indirect costs related to lost work productivity. So IBS is second only to the common cold in accounting for the majority of missed work days. And in terms of how it's relevant to women, so this disproportionately affects women. So there's a 2-to-1 prevalence, women to men. And if we look in the chronic population, that's closer to 3-to-1. So this is really impacting a significant number of women around the country. Worldwide prevalence rates are close to 14%. So we know that women are more likely to be seeking healthcare services, and so that could account for some of these differences between women and men. But there also are probably some true differences in how the disorder presents in women based on biological factors as well as psychological factors as well. In terms of how the disorder presents in women, women are more likely to have constipation predominant symptoms. They also tend to have a more severe symptom profile. So women are reporting more constipation symptoms, more bloating, and more significant symptom burden and reduced quality of life. So we really need more research to understand why this is. So we have a lot of theories, but we don't know the exact mechanisms that account for the differences among women and men. Some of these theories indicate that it could be related to hormonal factors. So we know that most common age of onset for women is late teens to early 40s, so during women's reproductive years. So that speaks to a hormonal piece. Even women without IBS report increase or changes in GI symptoms around their menstrual cycle, and about 2/3 of women with IBS are reporting looser stool and more pain symptoms around their menstrual cycle. And we also know one of the hallmark features of IBS is what we call this visceral hypersensitivity. So patients are experiencing, they have a lower threshold for experiencing GI symptoms and pain from their gut's nervous system. And some studies have shown that women actually have lower pain thresholds during their menstrual cycle. So again, speaks to how, there really is this, this physiological component that's predisposing women to develop this condition. We also know that the brain is processing these signals from the gut differently between women and men. We have fMRI studies that have shown this. And then, of course, there's sociocultural factors as well. So there's differences in reporting rates of symptoms based on culture, and also there can be greater stigma around these bowel symptoms for women that can contribute to how they experience and cope with the disorder. Something else that predisposes women to IBS is a history of early life adversity. So we know that there's a higher rate of trauma, early life adversity in patients with IBS. So about 30% of patients have a history of abuse. And again, this is something that deserves more attention in the research world. We don't know exactly why this is contributing to the development of this chronic condition. Some theories are that it really can influence the development of the gut's nervous system. So that could be, contributing to that visceral hypersensitivity, affecting the gut's microbiome. But again, we need more research to better understand this. And there is a significant impact on quality of life. So when we look at an IBS-specific measure of quality of life, some of the domains that get endorsed from women are food avoidance. Women develop a lot of anxiety around food, especially in social situations, not knowing what to eat, how it's going to affect their gut, certainly emotional distress, and interference with activities. So women talk about their lives really end up getting shaped around these symptoms. And a lot of women report having a sense of loss of control over their lives because of this. So they may not be socializing as much. They stop traveling, interferes with interpersonal relationships. So it has a significant burden in terms of patients functioning day to day. So you can probably get a sense that we really have to look at this from a biopsychosocial perspective. So there's this true biological component. We know there's this visceral hypersensitivity, the central nervous system component in terms of how the brain is processing pain signals from the gut. But then you also pair that with early life experiences, and then certain psychological styles, coping styles, anxiety related to living with these chronic symptoms, and all of these factors interact to contribute to the perpetuation of the symptoms over time, and this becoming a chronic disorder. So you can see how this really sort of sets the stage for the use of behavioral or psychological interventions, because our treatments can target several of these factors that we believe are contributing. And a lot of our traditional medical treatments have really proven to be inadequate in terms of addressing the full spectrum of IBS symptoms that patients are experiencing. And this is especially true when we look at patients with more severe and refractory symptoms. A lot of patients with IBS are sensitive to side effects of medications, and also a lot of patients prefer not to take a medication if they don't have to, and they're very excited about the option of having a behavioral treatment approach. So in terms of psychological treatments that we have available to us, we have 2 evidence-based treatments. We've got directed hypnosis and cognitive behavioral therapy, and I'll be talking more in depth about those treatments in October, so I'd invite you to come back and learn more at that time. But so just to give you a brief overview, these are short-term psychological treatments that are really targeting these cognitive affective processes that we believe are perpetuating the symptoms in patients. So the studies that are examining these treatments are looking at improvements in actual bowel symptoms and pain symptoms. We're not treating comorbid anxiety, depression. We're really targeting the condition itself. Treatments are short-term, they're skills-based, and what's really exciting, I think, in our practice here at Northwestern is that this is considered standard of care. So if a patient sees one of our GI specialists and is diagnosed with IBS, they're given an option of seeing a psychologist, of working with a dietitian, or trying a medication. So we have a wealth of research showing these treatments work, many randomized clinical trials demonstrating improvements in IBS symptoms as a result of these 2 treatments. And in terms of those specific numbers, so the number needed to treat for cognitive behavioral therapy is 3, number needed to treat for gut-directed hypnosis is 2, and I think what's really remarkable is the durability of these treatments. So again, remember, these are short-term, so patients are coming for 5 to 7 sessions, but they're learning skills to manage the symptoms, and we're creating changes in how the body is processing the symptoms from the gut. And when we follow patients years later, they're maintaining these gains. So just a couple of take-home points from today, really that this is a highly prevalent condition. So this is impacting a significant number of women, significant cost effect from this, and quality of life burden. And we really believe it's related to this brain-gut dysregulation. And we have psychological treatments that can target that are effective for helping women learn to manage this chronic condition. These are short-term treatments, they're skills-based, and often insurance will cover the cost of these treatments for patients. And finally, good news, this is a brain-gut issue. No one has to give up their chocolate. We have much better options for helping women treat this. Thank you.
Thank you very much, Sarah. And just before we close, could the Leadership Council members who are still here, if you could stand, we want to acknowledge you who are on the members. I know some were here and then left, and so they're at the back. Phyllis is at the back, and Fred and Sheehan are here. And Sarah's over here. So I really appreciate your leadership, and we also want to thank the Friends Apprentice as well as the Feinberg Foundation, which is on our last slide. But we really appreciate those individuals who have been strong supporters of the mission of the Women's Health Research Institute. And so I want to warmly welcome all of you back 1 month from now to another forum on osteoporosis prevention, diagnosis, and treatment with Dr. Paula Stern. And again, to thank all of you for participating in today's celebration, especially to our special guests who have been with us today. Thank you all.